So I'd like to introduce Stuart Irving from Norfolk and Norwich Hospital, and Will Finch, who kindly kicked off the questions, is sitting in the audience and has been part of making this video. Thank you.
Good morning, ladies and gentlemen. Thank you very much, Kay. We're sorry about our technical issues, and I'm very grateful that we've managed to save it in 3 different formats, one of which has worked this morning. The case I'm going to present today is a 39-year-old lady. She didn't consent to any external filming. She's diabetic, not the best control, and she presented to a GP over a while with recurrent urinary tract infections, one of which was a Proteus. She then came up as an emergency with colic, and she had a CT. She was stented by the admitting team, and then we saw through the stone MDT. So you can see the stone coming into view here, and it's not particularly radio opaque up on the plane image. This is the coronal CT. And if you look at the stone, it's a rather unusual shape. So we elected for a supine PCNL. As you can see, she was pre-stented. We popped a safety wire in, and we did a retrograde. And we've got 2 calyces here, which would be potentially amenable to puncture. We put a sheath up in the supine position, and we then went on to conduct a rhinoscopy. It's a slightly odd stone because whilst it's very long, it's actually very thin. And we did contemplate at this time, because the stone bulk was probably not what it truly would be for a 4-centimetre stone, perhaps we should laser this. But because of a history of sepsis and diabetes, we really wanted to ensure we got complete fragment clearance. So we decided after some time that this would not be a reasonable option. The rhinoscopy here is quite important. It's a difficult stone to get around, and we had some difficulty getting around to the lateral calyces on the left-hand side of the stone. Once we were able to gain access by manoeuvring the stone out of the way, we can then fill the system a little bit more effectively, and we use a combination of ultrasound, which our radiologists use, and some plain imaging. So we put some contrast up through the scope. And then using a combination of that, we can then assess the different puncture sites. We'd already looked at the CT, but after some analysis of the imaging intraoperatively, we elected that the lower pole puncture was probably not the most suitable because of the proximity of bowel gas. This is the CT, and we had a bit of bowel coming around the outside. This is what we elected for, which was a puncture into this calyx here. You can just see we're sort of wiggling the end of the scope, and our radiologists find that very helpful for identifying and being absolutely sure which calyx we're in. You can see the needle coming into view here in a second. There we go, and we use a 21 gauge needle, which is from Merit SMAC, and then through that we put a nitinol wire 0.018 and a 4 French introducer goes over the top of that. Once that's in, we put a wire in, a bit more contrast coming in there. This is the wire just looping back on itself. Once we've got a single wire into the system, we like to put a dual lumen in. So we use the cooked 10 French, and we put a second wire in. Jonathan Glass, who's near microphone 4, poised and ready, showed me this some years ago, and it's a great technique. So I do like a second wire, one inside the sheath and one outside. Next, we'll address some dilatation. In this situation, in this case, we used a balloon. We don't exclusively use balloons. We also use some semi-rigids. We don't get on too well with the alkaline dilators locally. This is the Nephramax balloon, which has a beveled tip, so we need to make sure we get enough balloon in. Microphone 1, please.
Yes, I was wondering if you might have considered grasping the wire, the first wire when it comes through, and pulling it through your sheath, so that way you only need 1 wire.
Yeah, we could. Yeah, we could do. The difficulty we had in doing that, we'd like to get one outside the sheath, but there wasn't enough room. But by having a wire in the sheath, sometimes we found it can impede movement of the scope, and what we worry about is damaging the scope on the side of the wire. So we elected not to do that in this case.
And for that, it really depends on the size of the sheath and the size of the scope. So if one has a smaller Olympus P6, for example,
Yeah.
typically there is enough room beside
Yeah,
the one.
with the Storz, it's tight. I'm just going to move on. We can see the Amplatz sheath coming into view. And then once the Amplatz is in, we can then move on and begin fragmentation. This is the view through the nephroscope. This is a calcuson coming in, and you'll see we've got some bubbles and some fluid levels. Because of course in supine PCNL, the Amplatz is below vertical, so the fluid drains out. So the system is often not collapsed, but often is not full of fluid. To be careful, we can see Will on the flexible ureteroscope poison ready behind, and whilst laser injuries are rare for us, thankfully, we certainly wouldn't want to have to explain a calcuson injury to the flexible ureteroscope. This sort of stone was quite soft. It's clearly an infection stone. It's quite brittle. We've used a combination of calcuson to fragment, but we've also taken fragments out just using a standard pair of grasping forceps.
Can I ask you a question from the app? So there's been a question about why you chose to do a supine PCNL for this particular case.
Well, we'd be very grateful we did. We've not exclusively moved on to supine, but I think in a stone of this size, there's always concerns that you may not completely clear fragments. And by being able to do a rhinoscopy from below at the end of the procedure, that can be very helpful in identifying residual fragments.
And the other question was about, do you have a preference for access sheath and size of access sheath?
Not really. The standard sheath we use is the 30 French Amplatz that comes with the balloon set. But if we're using the rigid dilator, sometimes we'll go onto a smaller sheath, particularly if somebody's had perirenal sepsis and has a nephrostomy, because the balloons we don't find always dilate those nicely. This is at the end of fragmentation, and this is our rhinoscopy, and this is a residual fragment that we had identified. This turned out to be quite a large fragment, not very visible on X-ray, and it was sitting in that lower pole calyx. With a standard PCNL, we would have missed that. This fragment was pear-shaped, which we weren't aware of at that time. So we began by using one of the Sacred Heart baskets, which is a nitinol basket, to try and lift the fragment out. Because it was pear-shaped, that wouldn't engage. We then had to change plan, and we moved on to some triradiate forceps. This again proved to be slightly difficult because of the shape of the fragment and the fact that the wide part of the pear was sitting in the bottom of the calyx. This step is heavily edited. This was very fiddly to do. I'll show you this is the flexible ureteroscopy series from this part. But what we found is we were constantly having to move the sheath and the scope from the kidney side back so it didn't impinge on the neck of the calyx. We finally got it into a position where we could move some of the graspers onto it and engage it. Now the other view from this tells a slightly different story. This section of film shows the rhinoscopy portion of passing the parcel. This is the flexible ureteroscope coming around and into the calyx, which is just here. So the neck of that angle is very acute. By drawing the scope back, we realised that we could get more room to get the fragment out. But with the shape of the fragment, we somehow couldn't get all of the fragment out easily. So the fragment was slightly difficult to get to the neck. So then I had to look at some options for teasing the fragment out. We chose forceps. And one of the difficulties that we have with forceps is the working mechanism. And the working mechanism of the forceps have to be completely clear of the tip of the nephroscope to allow it to work properly.
While you're doing this, I'll just ask you another question from here, which is how many flexible ureteroscopes have you damaged doing this procedure? Don't shoot the messenger, I'm just passing the question on.
With blowing our unit's trumpet, we did win the prize last year for getting the most uses out of a flexible ureteroscope. So thankfully not many.
And when it's appropriate with the video, there's been a couple of questions asking you to explain the positioning for a supine
Yeah,
PCNL.
we use a modified Galacco-Valdivia position. This uses a 2-litre saline bag under the loin. But we prefer to use 2 smaller bags so we can get a bit more access round to the back of the loin. We'd like to find a table which had a scalloped edge, because we find that the positioning on the edge of the table can again be slightly challenging. But the position is arm across the front, and then I won't demonstrate the leg positions from here, but it's arm across the front and then wedged over on 2 wedges, legs apart. This one bent up and this one straight. Sammy.
Yes, hi. Probably when Dr. Monga can correct me, when I visited him in Cleveland, he does most of his puncture on ureteroscopy guidance, and we use the prone position, as you recall. So I find it quite nice when you are sure where your needle is going, and you have the facility to do both retrograde and antegrade. The only question I have here in terms of the stone, you mentioned that it's probably difficult to go from the bottom. As it's not radio opaque, do you think it might, more like it's infectious stones, or could it be, what was the analysis?
Well, they are radio opaque. This was a struvite stone, but they're not densely radio opaque. So you could see it on the plain film.
So it wasn't uric acid then?
No, you could see it at the beginning, but you couldn't see it. You couldn't see it clearly intraoperatively.
Thank you. We've got questions coming thick and fast. Why didn't you use a flexible nephroscope instead was a question, but I think the video has subsequently gone on to show.
Yeah, we just wouldn't have got that round the angle. Our preferred choice, certainly with prone, would be to just use a flexible cystoscope and then just do a quick rhinoscopy. But in this situation, clearly that wouldn't have picked up that fragment. I'm just going to finish. We've got a couple of minutes at the end just to talk about drainage. This was a nice, clean procedure, so we discussed leaving this as a totally tubeless. But because of a history of sepsis and diabetes, we elected to be a little bit more cautious. We used just a 20 French Foley catheter that we put down through the tube, and then we pull the tube back, and then cut the amplat sheath off, and that served us very well. She was actually pyrexial for 48 hours post-operatively. We treated that with some IV and antibiotics, continued an oral course, and then she was absolutely fine. She's been seen for follow-up, and that's been put onto the registry, and she is stone-free and symptom-free and has been discharged.
Great. We've got 2 questions from microphone 1. One question from here, and then we'll go on to the next video.
It's more a comment, Stuart. I could see that you were struggling a little bit to get a stone that was with your stitch instrument that was just round the corner.
Yeah.
And I recommend to you a tool called a Perkins circle, which is a basket on the end of a straight instrument that is actually good at going just round the corner.
Yeah.
Thank you.
Just a quick one. The access sheath, when you're doing the combined procedure, do you always use an access sheath? Because I found that you talked about the decompression of the system with supine. I've tried to stop that now. I don't know what your thoughts on.
I think not always. I think in a case like this, where the ureter had been pre-stented, an access sheath will go in very easily. It just gives you the flexibility to not have the flexible ureteroscope occluding as a sort of surrogate ureteric occlusion device in for the whole procedure. You can put it in and take it out. So it just gives us a little bit more extra flexibility. And the unstented ureter would be less inclined to use one.
The last question was whether an upper pole puncture would have given you better access, which I remember was hotly debated at the Cambridge live surgery.
I think it's, to be honest, I think it's 6 2/3. If we went back onto the original retrograde, the upper pole didn't look to be particularly favourable, and those two, the lower pole and the interpolar posterior calyx, both look very inviting. So I think you put your access where it looks good.
Great. Thanks very much
Pleasure.
for your questions. Keep them coming. Thanks to Stuart for an excellent video.
Thank you.